يعطيك العافية Dr. Hussain. I'll try to be very fast here since we're talking about head and neck malignancies. We'll need probably more than 20 minutes, but we'll be really at a fast pace and we'll be stopping at the most important sections of this talk. In general, the head and neck malignancy has been a general paradigm for the last, say, decade or more. And this is the generally accepted treatment paradigm of head and neck malignancies. When it's at the early stages, we'll treat it with a single modality. When it is at the locally advanced or pre-local advanced stage, we would do a multimodality treatment, and the same goes with very locally advanced disease. And when we subdivide it into different sites, it will be oral cavity, nasal cavity, and paranasal sinuses, salivary gland cancer. These are generally better managed, ideally with a surgical procedure, followed by adjuvant radiation plus or minus systemic treatment, depending on pathological features. And of course, would be definitive chemoradiation if this cancer was deemed unresectable. Nasopharynx, oropharynx, larynx, and hypopharynx, ideally, we'd want to give radiation plus chemo if local regionally advanced. The goal here is usually functional organ preservation. Of course, there are many exceptions to that rule. And then transoral surgery as an option to the early stage laryngeal cancer or pharyngeal cancer. And of course, surgical procedures to the advanced laryngeal cancer as well. Starting off with nasopharynx, I think this is a classic trial that set off the standard of how to manage nasopharyngeal carcinoma. And they showed that treating a nasopharyngeal carcinoma with definitive concurrent chemoradiation, followed by adjuvant chemotherapy, would give impressive overall survival and impressive also outcomes in all different outcomes. And that trial, in fact, closed early, given to these wonderful outcomes. When it came also in testing the adjuvant setting of treatment post the definitive concurrent chemoradiation, this was a Chinese study testing this and tested the EBV population in general. And in fact, there was a lot of adherence issues with that approach. And that's why that survival benefit we saw earlier, we didn't see in this study. Also, we want to emphasize that the EBV virus in nasopharyngeal carcinoma had in fact been the driver of prognostication, and that was the New England Journal since 2004, and in fact set the standard to start this trial, and it has been accruing for quite a while right now by testing the EBV titers, and hopefully we'll get results soon about this trial. The induction trial, which that's the approach that I think the head and neck practice at our center is taking. And in the induction trial, we've seen that the distant mets improved and the overall survival improved compared to the definitive. And of course, there wasn't any adjuvant treatment. However, now there is the this new trial that showed that adjuvant capecitabine, following the definitive approach in advanced nasopharyngeal carcinoma, showed in fact that there was some improvement in free survival, favoring the capecitabine group. It was only for 3 years. However, it showed that it was significant. But to note that they included the high-risk patients. So before getting patients with the locally advanced carcinoma, you need to have one of those points, not all, of course. And if you have that locally advanced nasopharyngeal cancer, you could consider them for this treatment, but also bear in mind the toxicities that it would come with. This is another trial showing what if we had a low-risk nasopharyngeal cancer with EBV positive. And in fact, it showed that this earlier stages, the T3N0 disease, and it was, a prospective randomized control trial. They compared IMRT alone versus concurrent chemoradiation. However, they needed a set of things to be fulfilled before taking these patients into that arm. They had to have nodal sizes less than 3 cm, absence of A&E, EBV titers less than 4,000, and that identified them as low risk. And in fact, they have seen, if we go in depth into that trial, they've tested the patient with interim testing of the EBV virus, and they saw a trend of lowering of that EBV titer. And that's why it showed that IMRT, in fact, works just as well as the concurrent chemoradiation, and in fact, it wasn't considered inferior with a statistical significant value. And of course, the importance here, the grade 3 to 4 toxicity was 17 versus 46%. Moving on into metastatic disease now. When we have a metastatic disease, nasopharyngeal cancer, and they in fact respond quite well to the chemotherapy, should we consider local radiation? In fact, this is another efficacy and safety trial that it was a phase 3. It had accrued like 126 patients and showed that the 20-month OS was 76% for the chemotherapy plus radiotherapy group compared with 54. So it's an impressive number of benefit. But then again, there are few points that we have to consider in these set of patients. In this trial, there was no concurrent chemo at all, which would be impressive to see if this was done in a concurrent setting. About the majority were T3 to T4 or N2 and 3. 7 patients progressed, in fact, at the cycle 5 and 6, and all of these patients who progressed within 3 months after treatment. The partial and complete responders to the 3 cycles were required to be enrolled. So if you have a patient who responded quite well to that treatment, then we might consider local treatment and getting them through a 7-week treatment of radiation alone. Of course, it might not apply to those as well who progressed during chemotherapy. And also an important note in this disease, there were metastatic disease or oligometastatic disease, and the other oligometastatic masses hasn't been addressed as the oligometastatic trial. So that would be also an interesting approach to do. Oropharynx, I'm not going to dwell much on it because most of the trials were done on the HPV positive population. But this is the trial that actually set the standard and showed that the HPV positivity bear a good prognosis in general. I'm just going to talk briefly about the surgical role in oropharynx, especially in the early stages. And this is a really good paper that was done, in fact, by a surgeon, showing what's resectable and what's not. And in fact, it really showed, differences when the TOS was favorable and when the TOS was unfavorable. And in fact, showed as well some, differences in outcome with good statistical values. And they also attached many images in their appendix showing what's really, resectable and what's not. And it's in fact very useful to radomes and surgeons. And the ideal candidate, of course, for TORS, they should have a exophytic tumor or a lateralized tumor, minimal soft palate invasion, minimal base of tongue invasion, and a single involved node, no retropharyngeal node, absence of A&E. All these set an ideal candidate for TORS. So it's a bit, selective. And that's a trial that showed, in fact, transoral resection and approach in P16 positive patients that they have done quite well with impressive outcomes in different arms. and in fact set the grounds for other trials, but I'm not going to discuss here, Orator 1 and 2, and I don't think we'll spend a lot of time on it. Another trial that is currently enrolling for the HPV positive is Pathos for the surgical option. Now, when it comes into the RT option, I think the RT option for the early stages of head and neck malignancies is altered fractionation has been tested, and as we can see in the HANCA, that showed benefit in the local regional control and the disease-specific survival, but not OS. And the majority in there, it was tested on glottic cancer. However, this is an approach that is being done as well for the early stage oropharyngeal cancers, P16 negative as well, and can be considered. Chemoradiation, of course, the justification is quite clear for this classical trial group, showing quite a benefit. And we know in that trial, the majority were locally advanced. And there's a big justification in different groups that done these and showed that, chemoradiation treatment, in fact, has impressive numbers as compared to the other approaches. And that's a meta-analysis showing the benefit of actual platinum-based treatment. Treating it concurrently with radiation is still and remains to be an impressive approach. Bear in mind, of course, this treatment is quite toxic. How about induction chemotherapy? Many phase 3 trials showed no benefit over chemoradiation in the oropharynx, larynx, and hypopharynx. However, they're still reserved for special clinical situations. And that's one trial that tested it and showed really no difference. It wasn't worthwhile taking them in the neoadjuvant setting and then putting them through the definitive treatment. Same here, showing that there wasn't any differences except apart from the added toxicity. What would be defensible though for induction chemotherapy? I think when we have a patient's medical status that want to deem them fit, a very high potential of Mets, unavoidable delay in starting the radiation, impending local issues, markedly advanced neck disease with dermal infiltration, and markedly T advanced disease as well. How about if the events of the trials of getting rid of cetuximab in the P16 positive, and there are many trials from the European and the American group here, and showing in fact that cetuximab had worse survival than cisplatin. Then there's another trial that tried the approach of docetaxel, and again this showed equal outcomes. However, the toxicity and the hospitalization rate was quite high at the docetaxel arm. How about anti-PDL? Can we replace this or can we add it? For same answer, there wasn't much in terms of differences apart from toxicity. So how about if the PDL titers and expression is different? And that was tested in this trial. And the only thing that it showed is an improved 10%, almost I'd say 9% number. However, it wasn't statistically significant. So again, PDL doesn't work. How about durvalumab versus cetuximab? This, in fact, showed as well somewhat RT and Durva showed only signal of improvement towards PFS, but in fact led to worse local regional failure, and probably this trial won't be moving into a phase 3. What worked and what seems to be working is this SMAC, and basically the one sentence description of how these things work, how this medication works, is it restores the sensitivity of a cancer cell to apoptosis. And that's the phase 3 trial that has been recently published, the phase 2, trial of efficacy of ipsifambant. And it showed quite an impressive, OS survival result. But it was an efficacy trial, and the number of patients were quite not convincing enough to be a practice-changing approach. And they had this, the grade 3 dysphagia quite high in this ipsifambant arm. There will be two phase 3 trials, I believe, will be releasing the results soon, and we'll get a final answer on this approach. That's another trial which is trying also the introducing zivampant in the P16 negative and also P16 positive head and neck cancers. Just to wrap up in oropharyngeal cancer groups, I'd say we're already 5 minutes. Okay, so I'm just going to wrap up here in the post-treatment PET neck scan, just to inform you that, following up the PET neck should be slightly delayed when you follow up a response. I'm not going to dwell a lot on laryngeal cancer since we have only 5 minutes, and I don't think there's much of a change in laryngeal cancer apart from some hyperfractionation trials. In the post-operative setting, I'm going to skip through that as well because there hasn't been a lot apart from sentinel node biopsying. And the re-radiation setting, I believe that this collaborative group remains to be the standard to be followed by head and neck treatment when recurrence occurs. This is another paper to follow when it comes into the post-operative recurrence setting. This is a new nasopharyngeal trial that published the re-radiation specifically in nasopharyngeal carcinoma. And in fact, it showed that it indicated that BID fractionation tends to be safer. And it's quite impressive, and I recommend you to go into it. This is the topic that I want to dwell more time in, but I'm going to wrap it up real quick. As you can see, this is a locally advanced T5 disease, I like to call it. And it showed really an advanced disease in a 88-year-old female who's not fit to any sort of treatment, apart from palliative radiation. That's the response in 10 months, and this patient was treated in SBRT. Dose is 40 to 45 radium 5 fractions. A lot of people will be shocked to that dose, and understandably so, because all of the data in SBRT right now is retrospective. However, that approach is quite promising, as we have seen a lot of retrospective data showing that, in fact, this approach might be good in unfit patients. And there is a nice review that was published quite recently by several Saudi colleagues who actually wrote this review paper. It's quite impressive to see what has been done there. What's being done now, there's a phase 2 study that has started accruing since 2021, I believe. And they have accrued patients who are unfit for SBRT treatment, and the dose was up to 45 and 5. And this will be a prospective trial. However, the primary outcome is to only evaluate tumor response and squamous cell carcinoma patients. And these outcomes may not be convincing enough in taking this approach as a standard of care just yet. Although there's another trial that will be hopefully accruing by the end of this year. And it is a phase 3 randomized controlled trial that will be accruing patients in that SBRT arm versus the conventional standard of care arm of treatment. OS is the primary endpoint in that trial, and hopefully we get the answer from that from this trial. A word of caution in proton therapy. I think proton therapy is quite, nice when we see it in the dose painting and that approach. And when we've seen a lot of, evidence and proof that in fact it works better than the photon therapy in many cases, and also in the base of skull disease. However, this trial raised an alarm bell, I'd say, especially in the post-operative setting of head and neck malignancies and oral cavity malignancies. And in fact, they tested the ORN prevalence after proton therapy, and it showed quite significantly high result. I'll be concluding here with my talk. Thank you so much. Hopefully we have some questions.